people would go there to see, let's go and see how people who live with HIV look
like.
Even other doctors would come to see, and then they would say, hey, even that one, hata huyo. There are people who we should not forget. I always say sometimes, you forget where we've come from, and now we take it for granted. But they gave a lot. Living in the shadows is hard. Once you're out, you're out. It was hard. It was hard to be a person living with HIV. For me, I just feel like I don't know whether I would have had the courage. HIV isn't front and center among the things that they think about or that they worry about.
What they fear is getting pregnant. Welcome to Willow Health Media. This is Lifeline Dialogues with me, Dr. Mercy Korir. Joining me for this conversation is Professor Dorothy Mbori-Ngacha. She's a senior HIV specialist on the elimination of mother-to-child transmission of HIV, EMTCT, and pediatric HIV. She's a medical doctor, professor of pediatrics, and a specialist in infectious disease and public health. So it's 2024. It's 25 years since HIV was declared a national disaster by the then president, Daniel Arap Moi. And we just want to literally take a walk down memory lane on HIV since 1999. Of course, the first case of HIV was in Kenya in 1984. That's when it was recorded. But in 1999, 15 years later, that's when it was declared a national disaster. At the time, 13 out of every 100 Kenyans had HIV. Now we are talking about 4-5 Kenyans with HIV. So we want to look at the progress. What were the hits, the misses, the lessons that are learned to bring us all the way to where we are now? Of course, we are still fighting the epidemic, and we will win only when we have 0 cases of HIV in Kenya. Joining me for this conversation is Professor Dorothy Mbori-Ngacha. She has a wealth of experience in the field of HIV. She's worked in the development world, in academia. She's a pediatrician. So we'll get to hear a lot more about HIV from her during this conversation. Prof, welcome to our Lifeline Dialogues at Willow Health Media. We have conversations that really are everyday conversations that Kenyans have on their health. My first question to you is, at that time, I can tell you for free, 1999 I was in class 7.
Okay.
I just finished class 7, about to go to class 8. But at that time, you're already working. When the president declared HIV a national disaster, where were you and what was your reaction?
1999, you were in school. I was already working. I was working at the University of Nairobi as a lecturer and teaching and working in Kenyatta National Hospital as a consultant pediatrician. And it was a terrible time, You go into medicine to treat and have your patients go home, particularly as pediatricians. And we're in a space where our patients were coming and not going home because of the epidemic as it was. Our wards were filled with young people in their 30s, 40s, dying. On the pediatric end, and that's where my reflections will be with you, we had mothers with babies who were not thriving, who were sick, who were kept coming in and out of hospital, and they didn't understand what was happening. So it was a difficult time. HIV was highly stigmatized. And the narrative around HIV at that point was, it's a disease of bad people, bad in quotes. It's a disease of people who have led bad lives and they deserve what they get and so forth.
Was this because it's a sexually transmitted?
And so it was like sex workers, long distance truck drivers, and information coming from the West was, of course, men who have sex with men were also highly affected. So it was like a disease of people who had bad behavior. And yet here we are with mothers, young mothers who were just living their normal lives, testing positive, and their children testing positive. And so we sort of said, this isn't the whole story. And the University of Nairobi, we started trying to understand what's happening. How does transmission happen from mother to child? What are the risk factors? What is it that was putting these women? Because even at that point, women, the face of the epidemic was women. So what is it that was putting these women at risk? And it was a time when there was no medication. So 1999, nobody was getting treatment. So most of the care was home-based care and palliative care. Palliative care where you just want to keep people comfortable. People were trying out many things, even from the COVID pandemic. Whenever something like that happens, people, ginger, whatever, garlic, whatever, it boosts your immunity. So that's what people were trying to do. And faith communities played a big role at that point in time because they were the ones who were willing to go from house to house taking care. They were willing to give these people hope. People didn't feel comfortable around individuals living with HIV, and it was like you'd think twice. You would not sit at the same table and have a meal with somebody with HIV. If this was a mama mboga, you wouldn't buy your mbogas from her.
Yeah.
So there was a lot of stigma.
I remember even sharing utensils.
Oh no, that
they
was
had
a
to
no-no.
have different utensils.
Yes.
You don't even want to touch them.
Exactly.
And it didn't help that at the time, because around that time when there was some serious communication and public education about HIV, they had gross images that were really scary. I think they were just meant to scare everyone. And so you'd see, emaciated people. You're seeing the STDs themselves, if it's gonorrhea, syphilis, at their gross level. I mean, it was horrific because those images still live in my mind, and I was a young teenager then. Yeah.
So you wonder, I mean, it was, as you say, to scare people, to make people sort of like say, I'm going to change my... But, of course, we know that scare tactics are not really the most effective. But anyways, so there was a lot of... the response then was information, and palliative care, if somebody is sick, palliative care. And then trying to debunk misinformation. You can't get it from mosquitoes. You can, it's really basic. You can shake hands, nothing's going to happen. Because people were leaving their people who were dying to die alone because, I don't want to get it. Yeah, so it was a tough time. So by the time President Moi declared the disaster, we in the healthcare space had really experienced it. And even in the wards, there was a lot of stigma. There were rooms where of course, WHO kept saying, don't isolate. But people were isolating, saying, we don't know what's going on here. So people living with HIV in the hospitals were very lonely people. I remember, because we used to do studies as well to try and understand the pandemic. And I remember we used to admit pregnant women into the maternity wards to deliver, and nobody wanted to deliver the mothers, The midwives were scared. I mean, they had the gloves, they had everything, but they were scared. So it was a difficult time. 1999 was a really difficult time. And so when I sit today and look at it's a quarter of a century, I look back, I say, we've done, we've come a long way. We've come a long way. We lost too many. I mean, I lost loved ones, colleagues. We lost a lot of medical doctors and nurses. So that was the disaster. And because it was affecting the young people in their productive ages, it affected even workplaces. people were losing people who were in the prime of their careers and stuff like that. So today I can smile, but at that point,
it was a serious matter.
It was a serious matter.
So at what point, as a pediatrician, you have, at any one point, it's like you have two patients or three.
Yes.
There's the parent or parents and the child. At what point did you, as a medical community, know of the vertical transmission, or know this is how
it happens?
It happens, and so this is how we can save the babies.
You know, in the early 90s, people began to sort of understand the epidemiology, how it happens and what have you. And even here in Kenya, we were doing studies, I'm trying to think, 91, 92, we were doing studies on breast milk transmission. We were doing studies to see how other risk factors, the mother's own immune status and other, looking at different compartments, the vaginal fluid. It was really elaborate epi studies to try and understand what it was going on. So in Kenya, we were collaborating with our colleagues in the West, and this is one thing that really strengthened collaborations. You know, when there's a big thing you're fighting, everybody comes together. So we were working with colleagues at the University of Washington. They were doing most of the lab work because we didn't have the lab infrastructure, and we were doing most of the epi and clinical work to try and understand. So we knew how it was transmitted, we knew the risk factors, and then, of course, people started to see how then do you avert transmission. And studies were done in, the first landmark study was that 1999 when we were declaring the
National disaster.
We got good news from the West that antiretroviral drugs, which by the way were available for treatment in the West but not here, that those antiretroviral drugs could be used to prevent mother-child transmission. So the first study was a study of drug AZT, you know it well. But the problem with the study, it was bittersweet. The drug itself was expensive. Administering it required the mother to get it intravenously. So it was a difficult intervention. We couldn't visualize how we would be able to give it to women in the district hospitals and below. I mean, Kenyatta maybe, but lower level hospitals, it wasn't going to be feasible. So it was bittersweet, but it was proof of concept that you can actually do something. And it also made people start doing research to simplify how we give this treatment. So there were a lot of studies doing, how can we give less? Can we not, if we give it orally, would it make a difference? And so forth. So fast forward around 2003, we got very good news for low and middle income countries where the drug Nevirapine was then shown to be effective. The initial drug was maybe 67% efficacious, so 67% of the infections were averted. Now, for Nevirapine, it wasn't as high. It was around 50%. But we said 50% is better than zero. There's something we can do. What was good about it is that the mothers could get it just at the time of labor. As they came in, one tablet to the mother. And it would reduce the risk of transmission by 50%.
And it's easier to administer.
Yes.
And it's at the point of delivery.
At the point of delivery, right up to, you could do it even in a health center because it's a tablet, you know, it's not an injection or anything like that. So that was exciting, and we ran with that. So in Kenya, we started doing what we're calling pilot sites. And actually, we started our pilot sites in 2001 where we were asking ourselves the question, if anything is available, if these drugs become available, how would we do it? You know, so working with the implementation science, how would we test people? How would the flow be? Who would counsel? What sort of health workers would we need and stuff? So we had done that. So a lot of groundwork had been done. And then by the time Nevirapine came, we had pilot sites in Kenyatta National Hospital, the Karatina District Hospital, and Homa Bay District Hospital. Those were our 3 initial sites where we were saying we're going to see how to prevent mother-child transmission, working, of course, with the Ministry of Health, because these were Ministry of Health facilities. And, we learnt a lot, published a lot, and started to see where the pitfalls were. We were worried whether mothers would even accept to be tested. I came for antenatal care, and you're here telling me now I need to be tested for this thing. I don't want to be tested. I don't see where I would have gotten it from, etc., etc. And then learning how to counsel mothers and their partners and so forth. So it was a lot of learning around that 2001, 2003 period.
No, the ARVs, back then, like you said, were only available in the West, and they were, if available, very expensive.
Very expensive here.
How did we get to a point where we had them available, we had them free in the public sector?
Yeah.
Because that changed.
That changed.
Everything
So
in the course of HIV.
In about, there was so much work going on in the background also. So we are in the clinical space and treating and what have you, but there was a lot of activism and lobbying and people saying we need, challenging pharmaceutical companies. You need to reduce the cost of these drugs. You need to make them accessible. You need to make them accessible where the problem is largest. And sub-Saharan Africa, of course, has always been the epicenter. And so there was a lot of activism. There was a lot of, people really demanding their rights, the human rights-based approach and so forth. So around 2003, WHO said, fine, you people are so skeptical because people are saying, how can we take these drugs to Africa? They don't have healthcare systems. The
assumption that there's nothing that works here.
Nothing works here. How are we going to do it? So people didn't think we could tell time. So when you tell them they have to take the drugs 3 times, how is it going to be? There was so much skepticism. But WHO, to their credit, at that point said, you know what? Let's do proof of. Let's just try it out. So WHO said, now, if the pharmaceutical companies can reduce the cost of drugs, which they did to their credit, if we can get some drugs and start delivering in pilot sites for treatment, that's going to be a win. So around 2004, WHO started an initiative they called the 3x5. 3 million people treated in low and middle income countries by the year 2005. And it was an exciting time. For the first time, there were drugs in public facilities, and we were learning how to give the drugs, the side effects, how to manage. There was a lot of optimism at that point. So that was around 2004. 3x5 was it was successful. We didn't hit the 3 million mark, probably hit half that, 1.4 million people treated by 2005. Kenya was part of the initiative. And then from then on, it was almost like all systems go. We had PEPFAR and the Global Fund coming in around that time, saying, okay, so this can happen, this can work here. Let's show some global solidarity. So the other thing that I'd like us to just sort of pause and say, when we come together as a global community to address an issue, we win. Because they were already, their people were on treatment, they were fine, but then they extended that hand of partnership and solidarity and started funding programs in many countries, in many low and middle income countries, the most high burden countries, and Kenya was one of them. So we started, our PEPFAR program started around then, 2003 to 2004.
How did PEPFAR come along? I remember when we were just chatting before this, you
Yes.
told me there was a visit
Oh, yes,
that really changed everything.
Exactly. So, of course, I said I had already laid the ground. The narrative was very negative about HIV. There was a group of senators, and that time it was a Republican administration. It was
Yes,
Bush. Yes, Bush, the son,
Bush Jr.
Bus. So they came on a visit to Kenya, and we hosted them. At that point, I was also doing work with the CDC. So CDC being the agency that deals with medical, hosted them. And so they came, they went out to the field, they saw patients, they saw the mothers and the babies, and they were like stunned because for them in America, it was a gay disease. And then here they could see mothers, children. They went back to the Congress and said, guys, we need to do something. There's an emergency happening out there. People are dying. Children are dying. Children.
Yeah. Children and mothers are very emotive.
They tag, yes. Mothers and children are dying. We need to do something. I don't remember the name of the senator. I guess we could look it up. And Bush, who wasn't our favorite person anyway, for many reasons, politics aside, I love Bush. If anybody says anything bad about Bush, I'm going to fight you on it. Because he took a very bold step, and they did what they do, this bipartisan thing, and said, we're going to send money. And then that's how PEPFAR came, and that's how now countries started being funded. Initially, when the money came, we were like, what? It was a lot.
There was money.
There was money.
A lot of money.
A lot of money, and we had to get ourselves ready to go to large scale. Because initially we were trying kidogo, now we had to go to large scale. And so that's really what stimulated that response. And it's something that, it's good to have a legacy like that. We say in many parts in the HIV space, you say what you want to say, you Americans, about Bush. Us, we love him.
Because of the PEPFAR,
because
US
of the
President's Emergency Plan for AIDS Relief.
Exactly. And it was a broad response. It wasn't just about drugs. We had an epidemic of orphans as well. So there were many children who were just with grandmothers, some in child-headed households. And this program said, okay, we're going to do the whole thing.
I remember some of the stories that media were doing at the time were of villages that have just been wiped out.
Yeah.
You just have children, even the grandmothers are being affected, and the grandfathers. So it was just a village of only children.
I mean, I remember when we were doing work in Homa Bay, walking in some of the villages, and people say, oh, that home, there are no people. There are nice houses and everything. There are no people. I say, what do you mean there are no people? Wameisha water. Yeah. So it was really, the impact was, it was really
devastating.
I don't know. Devastating doesn't even seem to say it, but yeah, it was devastating and horrifying to see villages being wiped out, and the children just with nowhere to go. So initially, people did various things for the children. Sometimes they did orphan homes, blah. But then after a while, people said, we can't institutionalize kids. They need to grow in families and so forth. So with PEPFAR, there were really creative ways to see how to keep children within families, even if your parents are no longer, if there are other family members, or if there are other members of the community who, even if you're remotely related. So keeping families together. And that time, going to school was expensive. School was not yet free, you remember. We had to pay. And PEPFAR went into that space as well, making sure children would go to school. They had the uniform, they had the school bags, they were able to go to school and so forth. So it was a response that was very holistic.
So it was not just about providing treatment or tests,
It was
It was
very,
looking at
and then the other thing it did, which was very interesting, was like women who were widows, they got together into organizations, these chamas as we call them in Kenya, and then they would receive seed funding so that they could be empowered and they could take care of their children, they could take care of themselves. So it was really like a multi-sectoral response. They also did stuff with faith communities, because the faith communities initially, of course, it was, this is the result of sin, blah, blah, blah. But then worked with them now to start using their platform as a platform to bring people in, as a platform to share information, as a platform to really give people hope, rather, so there's not doom and gloom. PEPFAR also worked with people living with HIV, because people living with HIV says, we're the ones who know. We're the ones who know where it hurts. We're the ones who know what we need. And so we had a lot of support groups being formed, where people living with HIV could come together, do peer support and so forth. We had associations starting, UNAIDS Society, Kenwa, there were many, these AIDS service organizations that came together so that they could articulate their needs. They were also very important for putting a face, so they would come out, they would be on TV, like on World AIDS Day, talking about, I am so and so,
How easy or how difficult was it for people living with HIV at the time, considering the level of stigma around the disease? Because it's not just the person living with the disease, but also now their whole family and their children, because if you come up as an individual, then your whole family is probably going to be stigmatized.
Yeah.
How did they navigate that?
It was very difficult. There was the first person I remember who came out was a man called Joe Muriuki.
Yes.
And he was positive but healthy. So he didn't have AIDS, he had HIV. And I remember we always, does he really have it? There's some money these people are getting. There was so much skepticism and stigma. And when he came out and he had a family, of course, then people are looking at the family and what have you. One of my our colleagues at the University of Nairobi, rest her soul, she was also now living with HIV, and she joined that group. And she had a daughter, and she said she didn't want her full names to be used, because she didn't want her daughter, your Mercy Korir. So if your dad is there, I'm living with HIV, then when you're in school, there's that stigma. So she never used all her names. She just used her sort of maiden names, so that nobody would link her to her child. And she was always worried about that. So they gave a lot, the people living with HIV who came out initially.
Because that was courageous, it was
very
bold.
courageous, it was bold. And there are people who we should not forget. I always say sometimes, you forget where we've come from, and now we take it for granted. But they gave a lot, and the people lost jobs. I know, a friend who lost her job because she was HIV positive, and she had to come out and fight a legal battle to be reinstated. So it was hard. It was hard to be a person living with HIV, not only dealing with the disease itself, but also dealing with the stigma in society. And some of the stigma is your own self-stigma. You're just feeling like, how did I get this? And then some of it, of course, is the stigma of people saying she's shunning you in subtle ways. Even if people don't shun you directly, they'll shun you in really subtle ways. So,
in what ways did those few courageous people living with HIV coming out, in what ways did it change the discussion and the narrative around HIV at the time?
Yeah, I mean, it took a while, But after it's sad, but after a while, everybody had somebody who they cared about. So these people came out and said, I have HIV. I'm living with HIV. Is the correct terminology. So more and more people would then feel free enough to come out once they had the support groups and they encourage people and say, living in the shadows is hard. Once you're out, you're out.
It's like a burden has been lifted.
Yes. You don't have to, and of course you see, because there's no medication, the disease progresses, and after a while, you're not going to be able to hide in the shadows. So, but even when medication became available, people were still feeling very highly stigmatized. But these people coming out really gave others permission also to come out. So it's for me, I just feel like I don't know whether I would have had the courage. And some people were really affluent, well-to-do, had the medications and everything. So, and yet they came out to show that we are people. We're not, we're just like you. So it was the associations helped also.
You're saying the associations?
Yeah, people would go there to see, to let's go and see how people who live with HIV
look like. Okay.
And in our clinic, because we had a clinic for mothers and babies at Kenyatta, even other doctors would come to see, and then they would say, hey, even that one, hata huyo.
Because they look like you.
They look like you. Then they say, what? So it was learning for everybody. Even people who knew the science and everything, but the stigma was there, and so yeah, we needed them. We needed the people living with HIV who came out to begin changing the narrative, and they continue to play a big role. I mean, even today. They're the ones who keep calling us out. When things are not going, when new medications come and they're only available in the West, they're sort of like, hey, no. We're here.
We're also here.
We're also here. So they continue to advocate. When we are doing applications because like the Global Fund, you had to do applications as country teams so that, stating what your priorities are, so that they will be funded. And they'd come out and say, hey, no, our priorities are ABC. Don't forget we need ABC. So, because if it was left to us, the clinicians, we would say we want drugs and test kits.
And that's it.
And that's it. But they would say, no, we need all this other stuff. We need to take care of our young women, adolescent girls and young women who are highly affected. We need to understand why they're highly affected. We need money to do a little bit of evaluations and research. So they've been at the table advocating. Yeah.
So for the medics, the clinicians who were affected in the course of their duties, was there, at what point, first of all, did the medical community get to learn that this is how the medics can get the disease, and this is, what we need to do with post-exposure prophylaxis, for example? Because I know before the post-exposure, many doctors, and you've said yourself, really got the needle stick injuries.
They got the disease from there. And, it was too bi-directional. Because then there was this conversation around, what about if a doctor is positive? Can the doctor infect their patient? You remember there was you may have been too young. There was a case coming out of the US where a dentist infected many of his patients. I don't know how many was many now, but a number of his patients. And so that conversation was, okay, so how do we deal with this? Should doctors who are HIV positive practice surgery? Should they, so there's that direction. But then there was also the fact that we're highly exposed. I mean, I had a needle stick injury around that period of time. I didn't know whether the child was positive, negative, whatever. I freaked out.
It was, because I also had one when I was in internship 2012.
Yes.
And you don't sleep
You don't sleep.
because you don't know. You don't know, because you're just in the course of your duty. Yeah, I can relate.
Yeah.
Yeah.
So thankfully I didn't end up having to go on antiretroviral therapy or anything. But then part of, as things went on, there were guidelines around things like that. Blood safety, how to handle waste safely, how to, what to do if you get a needle stick injury, how to react. So we started taking better care of ourselves, because now the medications were available. And I would say that was probably around that same 2005 when now drugs were coming into the public sector. Before that, you were basically on your own. You get a needle stick injury, you wait and see.
Yeah, you wait and see.
Yeah.
And see what will happen to you. So when the medication started, the side effects at the time were almost as bad as the disease itself.
Some of the drugs. But it's interesting. It's like, when people undergo chemotherapy, your hair is going to fall out, what. But I'm alive, So people were like, they were grateful that these drugs were extending their lives, but they were toxic.
Yes.
They were toxic.
Yeah.
And many of those drugs now have been let go because, of course, a plug for science, because there are some people who say they don't believe in science and what have you. But the people kept researching for better and better formulations. And so drugs which were toxic, you could take off the formulary. You could take them off the formulary. Right now, we really have drugs which are not toxic, not that toxic. And we also have drugs that are easy to take, because, now we have a combination formulations. So you take one pill which has everything, and, you can just go about your life. But those days, you were taking many drugs, they were toxic and so forth.
I've interviewed back then there were adolescents going to high school.
Oh Lord.
Who were born positive because of the mother to child transmission. And one of their, because there's still stigma around HIV.
It will never, I don't know, human beings.
So they were saying, you know how they come in the bottles and you have many medicines, so they make a lot of noise. So if you are to take your medicine, if you need to go with them to class, or you're coming to school, it's making a lot of noise. So then everyone knows, this one is taking ARVs or taking something. So there's stigma. So what happened is they end up not taking the medicine because they don't want people to know that, you have all this number of medicines. So that the changing the formulation to like one tablet, I think, has made it easier for such groups.
It has. And, because we, in adolescence, people go to boarding school. And so also just working with the boarding schools to better support. Because otherwise you're hiding your pills, so better support. And I think it's getting better, but it's always them. People whisper, people discuss. But I think in many ways I sense that for this generation, the Gen Zs, etc., HIV isn't front and center among the things that they think about, or that they worry about, or that they, so...
Actually, they say there's medicine.
Exactly.
So what they fear is getting pregnant. They don't even think about the other STDs that, may come with irresponsible sexual behavior.
Yeah. So that is, that's the spin-off of the success of the response, is that people are now kind of getting complacent, so that's, I worry about that. I worry about people say, now, it's just like hypertension, or it's just like diabetes. And it's true, but then how will we ever end this pandemic if people are so complacent?
And they're the ones recording the highest numbers of new infections currently.
The adolescent girls and young women, they're really recording, and the younger people are really recording. Our age, I think, less so. And so you're looking at it, and we're doing very well in terms of treatment coverage. So people who know they're 95% of people who are living with HIV know their status, so we're testing at a high rate. 95% or close to 95%, maybe 93% of people living with HIV are on treatment, so coverage rates are high. And then viral suppression is also pretty good, same 90. So those metrics are good, but the tap hasn't been turned off. So you keep on getting new people. So these ones, yes, you're treating them, you're doing good, but the prevention response is where I worry about, because for young women, and we've pivoted a little bit, I'll come back to kids, but for adolescent girls and young women, despite the very high transmission rates and the new number of new infections in that group, we have interventions like PrEP, pre-exposure prophylaxis. But they are not taking, the uptake is not as you'd have expected. I thought that once PrEP was available, the young people would be rushing, and but you see, people don't see themselves at risk, so they don't. The uptake of PrEP isn't as high as we would want. I mean, Kenya is doing we're doing well. We've done a lot of the research that has informed the delivery of PrEP, or has informed the efficacy of PrEP. So we've done a lot of the research. Now we're struggling with, how do you get people to take the PrEP? Because it's an intervention that can be, it can help us just really break the back of the epidemic. We have PrEP tablets that people take, but then now there's also the long-acting PrEP, where hopefully people can take PrEP once every 6 months or once every 3 months, and that would be good.
Yeah.
So we hope that is going to change it, and so that young women can protect themselves better. But right now, we're still worried about the prevention part of our response.
Could it also be what we are seeing with, let me call it, transactional relationships and transactional sex, where the young women are, involved with the older men, and they're still involved with the younger generation? Because then, if we don't address this issue, then, as you say, that tap will not be closed.
It will not be closed. The social side of it is so hard to understand, but we know that there are a few things that work positively. Keeping girls in school longer really has been shown by research to be protective. And then also there are some interventions where people were sort of empowering the girls, doing sort of like cash transfers, programs where girls, instead of having to rely on sugar daddies and what have you, they're empowered in other ways, so that they can buy their pads, they can buy their, what girls need, and they don't have to rely on older men, So there's a program that PEPFAR initiated called the Dreams Project, and I think probably the girls you were interviewing were from that project. And it's showing that good results, that if we have a holistic support to the young women, that keep them in school, that keep them, enable them to live, fulfill some of their teenage dreams, then they're less likely to get positive. But it's hard to scale up. It's hard to scale up, because is government going to start
policing people?
Exactly. So it's hard to scale up. But we really need to think very creatively about prevention, and not think of it just as the medical thing, but you've started to touch on it, the socially. What are our social norms? And how can we address some of the social norms around these intergenerational relationships? How do we address that as a people? Because people, it's like it's a norm now that people have quote unquote sponsors. But how do we address that? So we have to have those conversations as people, as a Kenyan community.
Is testing? I know back then with the VCT centers. It was a way of, encouraging people to voluntarily get counseling and testing for HIV. Are we still seeing the same thing, or it's not as robust as it used to be?
Yeah, it's not so. But that time we were really blasting it. So right now, I think the approaches people are using more are trying to see whether we can encourage people to test themselves, self-testing. So, but those the tests are expensive. But self-testing maybe is the approach now we're thinking we can use, particularly for the young people. They love it. Go to this place, get it, test yourself, blah blah blah.
And you can do it in your private spaces.
Exactly. So that could be something that would be helpful. The other big campaigns, not so much anymore. When we say 95% of people know their status, then you're sort of like, oh, we're there.
We're there.
And yet we still know that, as I was saying, the tap is running. So we still have to have those mechanisms for getting people to know their status and encouraging people to test once a year or something like that, even if you don't think you're at risk. Yeah.
How was the introduction of mandatory testing for antenatal care?
Okay. Don't call it mandatory, we'll be short.
But it is mandatory because it's part of your
you see, when we
ANC
started,
profile.
Correct.
Yeah.
So when we started the pilot sites, that was the debate we had with communities of people living with HIV. They were sort of like, you're not going to force us. We're not, you're not going to force us. And we're saying, we're not forcing you. So it was a negotiation. It was really a negotiation because you didn't ask me, so now how come you're telling me I'm positive? And we had to even convince the Ministry of Health colleagues there and sort of say, and they were saying, why test these people if you don't even have treatment for them? Why test pregnant women? You don't have treatment. You're just
what will you do with the results? You'll just cause anxiety.
Yes, you're breaking people's marriages and so forth. So we did a lot of conversations, a lot of focus group discussions with the women. We did a lot of focus group discussions with male partners. We had to spend time with ministry folks and just sort of say, it's important because even though we might not have antiretrovirals yet, but this should be part of, it's just like a part of good healthcare for the mom. Just the way you do syphilis testing. You never ask people for syphilis testing.
Don't even ask for consent. You just test.
You just test and say, by the way, you tested positive for syphilis.
For malaria.
Go and bring your buana. And, so it was a negotiation and a process. And so when we started the pilot sites, we didn't think they would agree. We didn't think that women would agree. And they wanted us to do a written informed consent. And we said, no, it's going to be a barrier. Because if women have to sign anything, many women say, I have to go and ask the buana.
True.
Yeah. But if it's just part of the care, and people have been informed that it's part of the care and why it's important, then it would be easier. So it was a negotiation with the communities living with HIV and the policy makers. And so we call it routine testing with opt-out. You can opt out. If we're going to test you, we're testing you for everything, so you'll be told. We're testing you for everything, but sio lazima. It's good for you because, so it's good.
And also for the child.
For the child. But then you can opt out. And the initial study which we did to look at this opt-out, opt-in question was in Kisumu District Hospital. And I was kind of like, maybe 30% will accept, maybe over 80% of women accepted to be tested. Yeah. So, sometimes our fears are our fears as health providers. And the people just say, yeah, Pima, let's know what's going on. So it's been, it became routine fairly quickly after that, after we showed that women were accepting it and what have you. And even now, it's rare to find somebody opting out of HIV testing.
Hardly.
Because
I think at that time, as a pregnant woman, you're thinking about the well-being of your child.
There you go.
And so you're like, okay, if there's something, I'd rather take care of this child. I will deal with myself and whatever else later on.
And you see, when we had, so you've touched it, we had ARVs for prevention, the Nevirapine and what have you, but no treatment for the mother. And that's why people are saying, leave these mothers alone. You're creating stress for them. But when you talk to the mothers, they said, hey, if there's something that can happen for my child, yangu imeisha, I already have it. If there's something that can happen to my child, for my child, let's do it. You know, so it was really interesting. And the other thing I learned, we also sometimes think too low of our men, because we said, oh, these men are going to chase these women, or these men. So many of the guys, you know, it didn't happen. It didn't happen. Yes, she's positive. There were discordant relationships. Guys stayed together. And it really was, you know how it reassures your faith in humanity? You say, oh, you know, our guys aren't as bad as sometimes we make them.
As bad as we make them to be.
Yeah.
And so when it became routine, were you able as professionals to now pick out many women that were positive and therefore prevent vertical transmission?
Oh yeah. And so that was the whole point. So you test routinely, because you can't tell by looking who would have HIV. Then you identify the women who are positive, and then start having the conversations about, they start antiretroviral therapy. And you know, one step that we've missed, because I think we are meandering a little bit, but it's fine, because it's where the questions take us. Treatment became a routine thing for everybody in around 2013. You're tested, you're treated. Before that, you're tested. If you're not so sick, you wait. There was a waiting period until your CD4s go down, then you're put on treatment. But this was now test and treat for around 2013, in Kenya 2016. And so that was, it also made it very easy when people tested positive in antenatal care. You're not waiting. They're positive, you start them on treatment, and they go on like that. And treatment in the mother, the treatment was for the mom, but it also prevented transmission. So it was, you know,
killing two birds with one stone.
So yeah. So, you know, even our interventions have become more robust, let's say, from just single dose Nevirapine now to triple therapy for mom, which also prevents transmission in the baby. You know, so it has really evolved over time. And so this routine testing really helps you to know. Now, as we talk about this, you see, there are some people who don't attend antenatal care. So if you don't attend antenatal care, you'll never know. You'll show up in the system when you're already symptomatic, you have TB or something like that. So if you don't come for antenatal clinic, you don't get a chance to know whether your status. And so that's the other thing. It's important for us to really think about how we can get really, really higher coverage of, universal coverage of antenatal testing. And here I'm thinking about, in Kenya, we have like nomadic populations in the northeast. And, you know, you have people who are even here in Nairobi, but they don't go to antenatal care, people living in informal settlements and stuff like that. So that's the entry point. Once you get them tested, the rest sort of flows quite well. Yeah.
And so after testing, let's go to pediatric HIV. So some of the information and even stories that we've gathered over time, treatment for pediatrics at the time were still the adult formulations. Some are bitter, so that not even, you know, the child, it becomes difficult for a child to comply with treatment. How are you navigating this? Because you have something to prevent, but the medicine is not polite, if I may say so, to the child.
Yeah. So where we sit now, actually, we've overcome that hurdle, because now we have dolutegravir, which is really a really good formulation and very forgiving and palatable and what have you. But that, from around that 2003 coming this way, when children were taking those drugs, it was a fight. You fight with your child. Yeah.
And some are alcohol-based.
Yes. You know, it was a terrible time, and this is another thing why I say the activism, people saying no, we need to get better formulations for our children. Big pharma, of course, it's a business, eh? So they focused on drugs which were for the majority. The majority are always the adults. I mean, even in Kenya now, we have 1.3 or so million people living with HIV. I think maybe 70,000 children. So it's always a small amount.
Population.
But you sort of say, we can't leave our children behind. And, you know, I had the privilege of working with UNICEF for a while. And that was our mantra now. We must make sure that our children are able to get tested early, because if they're not tested early, if you don't test a child in infancy, 50% of them will be dead in the first 2 years. 80% of them will be dead by 5 years. So for children, the disease is rapidly progressive, and it's an emergency. So that was the push. Kenya has done well in testing children. That's one thing.
Could you just recap on the testing? Because I remember, I think at the time we were testing at 18 months. I think there was some challenge with testing for children.
So for testing for children, because, you know, when the child is born, the child has maternal antibodies. So you can't use rapid test kits. So you have to test using molecular tests in the first 6 weeks of life. So that's the so-called early infant diagnosis, so that you're able to distinguish the HIV that is
from the mother, and if it's with the child.
That's right. So early infant diagnosis was very difficult, because it's it's lab-based. It's molecular biology. There are not too many labs that do it, and so forth. So there's been a lot of trying to improve how to do that, bring point of care, and all that for testing young children, and we're better off at that. So
now we're able to do
early infant diagnosis, and because we have the technology that allows you to even do molecular tests at the point of care, we're able to do it much easier. Before that, because we're doing before and after. Before that, you had to wait until 18
months
to be able to know that this child is infected or not infected, if you're going to use the rapid tests. So that was also a challenge. And actually, case finding for children globally is a challenge. Kenya has done better than most countries, but we still are missing children who didn't get tested for the reasons we've just discussed. Mother didn't come for ANC, mother doesn't come to clinic, all that. So the child is out there in the mix, and we don't know that they're infected. So that's also a challenge that we need to really think about. And right now we have an initiative called the Global Alliance to End Pediatric AIDS. I'm sure you're familiar with it. Kenya is part of it. Kenya is one of the alliance countries. And we have to find those children and test them and get them on treatment. The good thing I know is that once a child is tested positive in Kenya, the linking to treatment
is fast.
It's fast. Okay. So we do a good job about that,
So in around 2013, 14, 15, and even I think some cases currently, for when I was working as a medical officer and my colleagues was working as medical officers, they are coming across young adolescents who don't know their status, their HIV status, because they got infected through mother-to-child transmission, and the parents did not disclose. They're actually coming at the AIDS stage when they have opportunistic diseases. What are we missing, or what is really happening? Because parents, I don't know, they should have a responsibility to disclose this, or even to do something about it.
Yeah. So it's tricky because of what we know about transmission. Now, mothers are hesitant to disclose to the child, because then I'm the one who gave it to you. So there's that.
Is it guilt?
It's guilt, it's stigma. Mothers are also protective of their children, protective. And if the child is still alive, then let's just continue. Let's just continue. So there's it's complex. It's complex. I find I would not judge a mother easily, but now that we have medication, we really are encouraging disclosure to children early on, and disclosure is a process. It's not like one day. It's a process, and we also say that around age 7, you can start telling the child in simple ways. And we also have tools that will help parents to disclose. So it's a difficult thing, but it's a journey that parents have to take, so that by the time then the child is at that adolescent stage, they know their status and they know why they're taking medication. You know, there was a girl who was giving her just sharing and saying that she used to wonder why in her household she's the only one who takes this vitamin. Because, she was told it's vitamin. Come on, vitamin, why isn't everybody taking it? Sort of a thing. And eventually, of course, she found out that she was positive. But those who come in late, and that's our worry. That's why we have this, what I was calling the Global Alliance to End AIDS. You see, when we're not even talking about any HIV, because HIV is there. If you already have it, you have it. But to avoid AIDS, right now we're having these children who are missed. We didn't test them in infancy. They survived. They are long-term
20%
survivors.
who survived beyond the 5 years.
There you go. So they survived. They are, the child is maybe not as robust as the other children, but the child is alive and going to school and what have you, until they develop AIDS, whenever they do. We're trying to see how can we find those children. And I was speaking with colleagues at the national program and also at the UNICEF people, and they say that's now their focus right now for pediatrics, is finding the children, finding these children who we have missed. Right now, we've treated 70% of children who need treatment. We are the 30%. 30%. So that's the challenge to us.
And those are now the late teens, early 20s.
The ones who we would find who are perinatally infected are usually early teens. Early teens. The late teens, many times they got it around, then it's horizontal, not vertical. But yeah, some will survive up to late. And our thing is, how do we encourage people to come in? How do we? So we're trying to link it with their parents, because we know this by transmission, mother to child transmission. It's from a mother. People don't like mother to child because they say we're blaming the mother. But biologically, it happens from the mother to the child, the vertical transmission. So we're now having a program where they're testing. When an adult tests positive, you are asked to go and bring all your children of whatever age, not just the babies. Because before that, we say, bring your babies, and they bring their babies and we test them. But now it's sort of like
the whole family.
Come with your household. Yeah. And that's that index testing, where if you're found positive, you're told to come with your household, is one way we're trying to see, can we find a way of mopping up children? If you find a child who's positive, then you also ask for their siblings to be brought in and so forth. So we're trying to be a bit creative around identifying children, identifying them early. For children, it's you lose a lot when you don't identify them early, and that's why we're really like, let's push for early. Let's not wait until they come in with cryptococcal meningitis at age 10. That's AIDS. We don't want AIDS. Let's find them early, put them on treatment. They can live long, healthy lives, as we are seeing. We're seeing now people who are children who are perinatally affected, or adolescents who are perinatally affected. They're now mothers because they were able to get the treatment. So I think that's a challenge to us as a Kenyan community. I think that's a gap that we really need to focus in on.
And it will require also a lot of psychological and mental health support. Because if
Absolutely.
it's a whole family and these are young children, young adolescents, it will require a lot of holistic care for
Absolutely.
them, not just the actual physical
Physical
care.
testing and what have
Yep.
you. And you see, the thing is also for the young women who were perinatally infected, and so they're living with HIV, and now they're in their teens and their 20s. Again, that's another disclosure. So disclosure is so complex. It's disclosing to the child that, oh, by the way, you have this. And then when this child grows up and they start having relationships,
They need to
disclosing
disclose.
to their partners, and how does that happen? And it's not easy.
Not easy.
A friend of mine was sharing with me her nephew of hers who met this girl in church, and they like each other now. They want to get married, and the pastor says, you need to go for testing. I think it's the norm these days or something.
Yeah.
Yeah. Nowadays it was not there. So they go. They have the testing, and they're confident. She's confident, and she tests positive. And then, oh, how did this? Then they do it, and then they find out that of course she's perinatally infected. Now, the parents of that boy, you're not marrying that.
We don't want to hear anything about it.
Exactly.
Stigma
So,
again.
stigma. So it's so complex, Dr. Koriri. It's so complex. And just what you said, we need a lot of psychosocial support, psychological support, the support around how to disclose, the support to the people who are being disclosed to. Yeah.
So HIV seems to be even sort of a bigger social issue, maybe because of the nature of transmission. So talking about the social aspects of disclosure, there's also the social aspect of transmission and some of the things that are introduced, like medical male circumcision for those communities. What other social risk factors for HIV are there that have been addressed or that need to be addressed?
They need to be behavioral. You see, medical male circumcision was a medical intervention, yeah?
For a social practice.
For a social practice, yeah. Okay. So that one was a little bit not a hard sell. After a while, you go to Luo Nyanza where they don't traditionally circumcise, you find most young men are circumcised because of that.
Wife inheritance.
Now, that is where I was coming. The cultural practices that put women at risk. That the wife inheritance, the widow inheritance. Church communities have tried to work with communities to sort of say, it doesn't mean when you do this inheritance thing, it doesn't mean that you have to have a sexual relationship because it's what is perpetuating it, So culture dies hard, but slowly people are beginning to sort of say, those practices, they're putting our people at risk. We're not going to do it. But some people are still doing it, And many times, because, it's easy to judge. For the widow, it's survival. Yeah. My husband's brother is going to take care of us.
And
me and my household. Children and the whole household. So sometimes it's a survival thing. And, it's difficult. But
it's like they've been put at a place where they don't really have a choice.
No, a rock and a hard place.
Yeah. What do you take?
What do you take? So because it's still happening, but it's one of the social risk factors that were there. There were some bad ones because there was a time when there was a belief that if you have sex with a young virgin or something like
yes,
then
you'll be cured.
Things like that. So there's a lot of those bad sort of, you don't know where they come from, misconceptions, myths that were perpetuated during that time. Thankfully, because there's treatment and all that, they have more or less died off, And
what kind of, let me call them alternative treatments, especially before the ARVs, what kind of treatments and things were people doing to...
Before I revised, there were many things. You're desperate. You're desperate. When you're told that this thing can kill you and there's no medicine for it, traditional healers come up and they always have some sort of...
They always have something.
This ukikunywa, So there was a lot of traditional
herbs and
all that concoctions that were put, and people would hear of, huko Tanzania, there's somebody who is curing AIDS.
And it's always Tanzania.
Yeah, I don't know why. so there was a bit of that. And then even because we were kind of stuck, just the normal things we usually talk about for, and I think we spoke about it earlier, for boosting your immunity, garlic, ginger, just the things people did during COVID. See, COVID, people drank a lot of garlic.
Lemons were like gold. And ginger.
Exactly. Anything that you feel can boost your immunity. So people did a lot of that sort of a thing. There was prayers also. People would go and say, I've been prayed for Sasa Mubiri. I said, I'm fine.
And they stopped the medicine.
Yeah. So where there's limited knowledge and limited options, people do things, desperate things to survive. So
to give them hope.
So I don't really, you don't really blame them that much. But it's important that now people like you who have a big platform should be able to help people deal with those misconceptions and debunk them. Yeah, because it's you can tell people whatever you tell them, but with your big platform, maybe some of these are things that you can keep on as we go along, because there'll always be some myth or other coming up.
Yeah, there's always something new coming in.
Yeah.
So for the key populations that have been identified as high risk, the men having sex with men, the sex workers, truck divers, injecting drug users, are we making any headway with those particular populations because they are higher risk than
they're higher risk.
The rest?
We've made progress, but they are behind. Treatment coverage for the general population, the whole population is at 95%. Treatment coverage, or 93 or somewhere there. For key populations, treatment coverage hovers around 40%.
That's very low.
It's very low.
Very low.
Because of, again, stigma. Access to services, you come here and people realize that for men having sex with men, people realize that that's your orientation. They
judge you.
They judge you. You yourself judge yourself, so you don't even come in the first instance. So it's a difficult thing. PEPFAR has programs that target specifically supported programs. Let me not say has programs. PEPFAR supports programs. So PEPFAR has supported programs in various parts of Kenya that are run by NGOs, civil society organizations that target these key populations and just sort of make sure they're able to access services, condoms, lubricants, all that sort of a thing. So it is there. I don't know now, once PEPFAR transitions out, how those programs are going to be sustained, because you know that a lot of the key population issues are very emotive.
Very emotive.
And
especially when you start thinking about the men having sex with men, the sex workers, or the injecting drug users.
Yeah. For me, I always say we should always separate public health from
our personal biases and beliefs.
Yeah. Because when HIV first started, sex workers they're the ones who are... But you know, the thing is, if you don't treat them, who are the people who go to sex workers? So
everyday people.
Exactly. So, it's a public health response. It's not that you are condoning the behavior. You may not even condone the behavior, or you may not care, but it's a public health response. You will stem the infection here because then it stops it from spreading to the general population. So I think we need to begin to think about things with a more public health lens, and then the social, the moral is another story.
And if you look at it, sex workers have also played a key role in research.
Yes.
Yeah.
Yes, particularly colleagues in the Department of Microbiology, working with the Canadians, they did a lot of research. In fact, some of the research that they participated in, because they were the Majengo women
Yes.
who were really, they were not getting, despite repeated exposure,
They were not getting
infected.
positive.
So they had to understand their immune responses. And that could inform future vaccines, So they have participated in that way. And I think it's a difficult place for people to navigate, and people become very fundamental. But I always just say, you know what? You believe what you believe, what Jesus says, what Muhammad says, etc. That's fine. But now this is just public health. We're just trying to deal with the public health. We're not saying it's right. We're not saying it's wrong. We're just saying that we have to deal with this as a public. Yes.
Let's address it.
Yeah.
Are we likely to see significant developments in treatment, like maybe a once-a-year injection, maybe twice a year?
Inshallah. I think so. I think people are really becoming ambitious. After we got this lenacapavir, which is the prevention medication that you take 3 monthly, 6 monthly, and maybe now it will be even annually for prevention, people are becoming ambitious and saying, okay, so why not even for treatment? So I am optimistic. I'm optimistic because the pharmaceutical industries keep pushing the envelope on this one. And for so long as their research is funded, there's hope. There's hope that it could be that. And I want to be optimistic that we'll be able to end this, and we'll be talking about it sitting by the fireside saying there was a disease, that sort of a thing.
Like the way we talk about smallpox.
Exactly.
So is a vaccine likely? It's been elusive, tough because of the nature of the retrovirus.
Yeah, it's been tough. One step forward, two back, one step forward. But the vaccine research is ongoing. Cure research is ongoing. Where, yes, you got it, but you're cured. And, so there's a lot of research going on. And I'm proud to say that Kenyan researchers are part of these studies and making a difference in that way. And I wish our governments would also put more money into research, because right now we're relying a lot on funding from external sources. But yeah, there's hope.
Is the Kenyan government likely to do that? Because if the donor funding is coming or has come to an end, we need to put in the funds there. Is there likelihood that that's going to happen? Because sometimes I usually feel it's the willingness to do that, not the lack of funds as such.
Yeah. And right now, what is going on in the PEPFAR space, and I'm sure even in Global Fund, they're transitioning countries. So sort of like, guys, it's been 25 years.
Yeah. We can't be hand-holding you for another 25 years.
Exactly. So I think I have hope for Kenya, though, because I remember right at the beginning when treatment became available, ARVs, the Kenya government put money on ARVs. So it wasn't fully funded.
Okay.
It could have been a token amount, but at least they put money.
There was something.
There's money that we could say that we're also treating our own people. And I think that attitude, if we continue to hold that space, we'll be able to fund our own response. We might not be able to do all the other fancy things, but at least for testing, treating, some of the other interventions, opportunistic infections and stuff like that, I think we should be able to manage it as Kenyan people on our own. Besides, the cost of drugs has gone down,
significantly gone down.
Yeah. Again, activism, and solidarity has brought that cost of the drugs very low. We have no excuse. I agree with you. We have no excuse not to be able to fund our own response.
And what of the triple elimination?
That's a pet topic of mine. So we're talking about ending new cases of pediatric HIV. And then we sort of said, why stop at HIV? Syphilis is transmitted from a mother to her child. Hepatitis B is also transmitted from a mother to a child. So we're now, and countries, member states, including Kenya, have signed up that they want to eliminate mother-to-child transmission of all three conditions. And so now we're trying to re-engineer our programs to be able to test for syphilis. We're already doing, HIV we're already doing, to also test for hepatitis B. And then have the interventions to prevent transmission from mother to child. So it's an exciting time, to be able to then clear those three diseases. Hepatitis B is very important, as you know, because that's when somebody's 30, 40, they get liver cancer, and you sort of say, where did it come from? If you are able to prevent hepatitis B at around the childhood space, then you're able to prevent liver cancer. Yeah, and of course, syphilis, we know the impact. Yeah, so it's an exciting time in the space.
So it seems like if we do a lot of focus around the mother and child, we can sort of prevent probably 75% of the problems up ahead.
Yeah. If we do a lot, of course, people always say, what about the men? And I love men. I have nothing against them. Right? You see, because of the impact of this pandemic more on women than men, so the focus has been on them. But I think the men have also gotten their due justice has been done also for male intervention. Our only problem is men have very poor health-seeking behavior.
Very poor.
Yeah. To get a man to come into the health, he must be...
They're probably dying.
Exactly. So that's the other thing we need to sort of tell guys, get tested. Even if you feel nothing, once a year, just know how things are, So for men, their interventions are for themselves. For the mother, the intervention is for her and the child. Well, I guess for the man, it's also for the partner. Okay, so it's for somebody else. But for the woman...
There's a direct impact on the child.
Yeah. The future generation. Yes. So,
so what would you want to see in the next 25 years?
We're talking of ending AIDS by 2030. Why are you talking 25 years? 2030, how many years is that?
6.
Okay.
6 years. but we've come a long way because looking at this conversation, a lot seems to have really accelerated between 2016 and now.
Correct.
Those are 8 years.
Yes.
So I think
there's hope.
There's hope.
There's hope. For me, one of my dreams when I was working in this space, and I laughed at myself the other day, I said, by 2015, we will not have any child being infected with HIV. Here we are in 2024. So, it's good to be ambitious, but sometimes you miss the mark kidogo. But I still believe that we'll be able to end pediatric HIV. We have countries, I believe we can do it in Kenya. We have countries that have already been validated by WHO that they have eliminated pediatric vertical transmission in their countries. And that's where I want Kenya to be for vertical transmission. We are on the cusp of having epidemic control, where when we hit the 95, that means that then HIV is now no longer considered a public health threat. Not that it's not there. It could be there low-key, but it's not longer a public health threat.
So it's 95 for testing, 95 for treatment, 95 for suppression. Viral suppression.
Yeah.
Okay.
Yeah.
All right.
So I am optimistic that we're going to get there as Kenya. And as we go along, I'm optimistic that we will also remember to bring along us the populations, like the key populations and so forth. Because unless we all come, unless it's for everybody, then it will not be success. So that's what I'd like to see going forward.
Okay. Thank you very much, Prof. This has been enlightening and, refreshing. I'm glad to see that, many years of work has brought us here. And we hope that in the next 6 years, by 2030, we'd have a different conversation, like
Correct.
we've eliminated, especially pediatric HIV. So thank you very much for your time. Thank you for gracing us on Lifeline Dialogues.
Thank you so much for having me.
Thank you.